sharing my screen. Sorry, I just.
So, are you ready to? Jadip, are you ready to share your screen? Or maybe we could leave it for a little later. If we're not, okay, oh, that's fine.
Is my screen visible?
Yeah, we see your screen.
Is it visible now?
It's a Retinawesome, yeah.
Is my screen visible, Dr. Hudson?
No, the slides did not appear yet.
It's a video.
Just a second. I think I'm going to be able to share yours. So just a second. Let me get your video. Just a second here. Okay, deep.
Hello everyone, the title of my video is Sometimes Pulling Doesn't Win You the Tug of War. I have no financial disclosure. Many a times while operating a case of vitreomacular traction, by pulling at the vitreous, we end up developing a full thickness macular hole resulting in a central scotoma to the patient. So here I present a case of a 71-year-old lady with no systemic illness. She had a history of macular hole surgery done in her left eye few years back. She complained of distortion and metamorphosis in 6 months, which was progressive. She was pseudophakic in both eyes. A pre-operative OCT showed a tabletop traction at the fovea with a vision of 6 by 12 and 10, and the other eye had a closed macular hole. A standard 25G pars plana vitrectomy was planned. After core vitrectomy, triamcinolone was injected to stain the vitreous, and careful dissection of the posterior vitreous was done around the macula to prevent any undue traction at the area of the VMT. The cutter port was always kept away from the center of the macula to prevent any traction there. 360-degree truncation of the vitreous was done to separate all vitreous attachment from the center of the macula and around the ONH. Careful induction of PVD was done on the nasal side of the ONH to prevent traction at the macula. After truncation, it was found that there was another layer of vitreous which was still present underneath, and so that was dissected too before we started trimming the area of the vitreomacular traction. After making sure all attachments of vitreous are separated, then the area of the vitreomacular traction was approached and trimmed. After this, peripheral vitrectomy was completed. After completing vitrectomy, fluid gas exchange was done and the ILM was stained with brilliant blue-green dye, and ILM peeling was performed using a ILM peeling forceps. In this particular case, the ILM was peeled across the foveal center However, fovea sparing ILM peeling is recommended to avoid full thickness macular hole formation. Thank
Very good, JDip. Very cool case and good imaging as well. And we started now, since we have all from the FA meeting arrived. And I wanted to discuss before we start this case from JDip Wallinkar. JDip, could you comment a little more on such an interesting case with good imaging and vitrectomy with PVD, brilliant blue, ILM peel, and do you like doing ILM peel for all those cases or a high percentage of them?
Right. Thank you, Dr. Alson, for having me. And basically, this case is to highlight that ILM peeling may not be necessary in all the cases, as we have a lot of literature evidence, but recently there has been a group of evidence which says that fovea sparing ILM peeling would be beneficial in cases of vitreomacular retractions like this. So recently I've started peeling the ILM. Initially I was peeling the ILM across the fovea, but that has a relative risk of again causing iatrogenic macular hole formation. So there is a group of evidence which says that it happens, but not in all cases. So I would like to get an opinion from our esteemed panelists here, what they prefer if they are doing vitrectomy for VMT in these cases, and whether ILM peeling is necessary in all cases or they would reserve it for certain cases.
Yeah, what do you think, Lucan? Would you do the same, and would you carry on the ILM peel in such a case?
In the shown case, there was a cases of highlight, which was referred as the second layer of vitreous. So the only way to be sure that you removed the remnant hyaloid is actually to perform an ILM peeling. So I would do an ILM peeling, and nowadays I tend to spare the pupillomacular bundle, and it's a limited peeling or temporal ILM flap when it comes to full thickness macular hole.
Yes, true. And Ahmed, would you have any comment? And I like the pretty much very beautiful the way he peeled off first the hyaloid with very good staining. So I think it got easier to approach and remove all hyaloid from the macula and make it safer, the procedure.
So I usually stain the posterior hyaloid in every case actually, but in this type of case, if I'm worried about causing any complications in the fovea, I usually do also ILM, but fovea sparing.
All right, cool case. Cool case. Would like to comment anything else? Anybody? Or even you, JDip?
Right. So that was useful. Actually, my question was whether how do we isolate or make sure that this area of the VMT is not having undue traction, because any role of intraoperative OCT in these kind of cases, and whether that would be really useful to prevent iatrogenic complications, because we don't have it all the time. And is there any other way we can avoid, because sometimes you don't see the traction underneath these vitreous schisis, so any way we can prevent it from happening, any other way of performing the same steps?
All right, so I just want to say hello to Natarajan, just arrived, And Natarajan, J-Deep is here. Finally, he approached us to the Retinawesome meeting. So how are you doing, man? You just arrived? And I want to say hello also to Frédéric Matonti. Comment ça va bien? Ça va bien? Nous parlons français ici aussi.
Thank you. Yes. Oh, this is perfect. Thank you. Sorry for I'm a little bit late.
Thanks a lot. And thank you, Jaydeep. Thank you for starting off this session. I know it's your birthday as well, and you have celebrations for your meetings in India. Thanks a lot. And I want to say hello to Dr. Alan Franklin, who is the mentor of this meeting. And I've met Alan Franklin back in VitreoRetinal last year in Hamburg, and I had a great opportunity to watch his presentations. And also, we want to discuss very cool cases on FA and vitrectomy. I'm very happy, and people are very happy. This is being recorded as well for the ophthalmological community. And so it's a great pleasure to welcome Dr. Alan Franklin in name of all of you. Thanks, Dr. Alan.
Thank you for having me. It's an honor to present today with this great faculty, and I really appreciate your efforts of putting together such a nice meeting.
Oh yeah, it's an honor. I also want to welcome Viper Seti. My audio is a little better now. I was a little far. I think now you can hear me better. And so, Dr. Alan Franklin from Alabama, if I'm not mistaken. And are you ready to present your case, your keynote case?
Yes, sure. I've got some short video, and then I've got a little something on fluorescent.
Okay. You want me to present it, to display it from here, or you prefer to present it yourself?
I can present if that's okay.
Sure, that's okay.
Can you see my slides?
Yeah. It's not yet full screen. Yeah, now it is.
Okay. So there are a lot of people that are working on this project. A lot of people that are talking today. Doctors Mishev and Abro have been great colleagues and collaborators to work this through, and Dr. Sosa working with Dr. Abro. I'd like to acknowledge our resident Lexi Gibson and medical student Allie Wynn, who've done great work on this. So intraoperative fluorescent angiography was originally developed by Steve Charles around 1980, who's developed a bunch of other stuff. Bob Avery and others at Hopkins later in the 80s were working with it. And with the old optical cameras, it was the imaging was limited from the camera resolution and the low dynamic range, and there was really no wide field imaging. So when 3D DABS came out, Dr. Imai has done some really pioneering work and elegant work that really developed intraoperative fluorescent angiography that looked good for the first time, and always look forward to having him talk, and we'll have him talk later today. We and others adapted the fluorescent angiography to use with the Constellation. So it's less, we'll see in just a few minutes, it's very efficient. Once you get a little bit of machine work in, there's a filter holder in the older Constellations, and you can put the filters, the exciter filters in the older Constellation, and then the digital filters. I've got my email at the end of this, but I'm happy to share with anybody the digital filters, we're now, instead of using a barrier filter in the microscope, we use these digital filters in the Ingenuity, and they work pretty well. Dr. Mishev has really done some great work in terms of optimizing the parameters for fluorescein angiography, both looking at the spectral output of different machines, different light sources, and the spectral output of different exciter filters. But the Alcon machine he's shown has got really probably the best output of the commercially available machines for light for intraoperative fluorescein angiography. So once you do this basic setup of the machines and the Ingenuity software, it's basically good microscope settings, what you would do before your OR. You have to be careful to be parfocal in your light sources. Fluorescein does degrade after 5 minutes or so, and fibrovascular tissue is a little more difficult to image. This shows you how quickly we go to fluorescein in the...
Let's go to fluorescein.
So, fluorescein...
Yeah.
My anesthetist is starting to inject, and the fluorescein's in, and we're just watch it fill. Obviously, the screen won't be all that clear. We're just doing a shot on the Ingenuity. And what I'll usually do is put the pressure down from the machine and then aspirate to make sure that the eye is relatively soft. Because one thing we've seen is the pressure's up, there's just no perfusion. So this is a diabetic that's had a bunch of work. Can see as the fluorescein is coming in another couple of minutes, or another minute or so, we'll see along the superior arcade there's some leakage right there. And so within about a minute, we have an answer that we're seeing some residual hot spot or leakage that we're going to go ahead and treat. So it's really very seamless to go to fluorescein imaging and then back to regular imaging in the operating room. In terms of what, the visualization, I've got a few cases here. This is a diabetic, and it's really transformative to see how well you can see in these eyes here. So some residual neovascularization, just a little bit that we're peeling off. And then the ischemic retina that we saw earlier, we're applying heavier laser to the ischemic retina while kind of sparing the less ischemic retina. This is a RAMA. And with fluorescein, you can really see the extent of the RAMA. These are some residual leaks that oftentimes you don't see after you do a peel, and we're treating those, and we're getting good results with this. This was a diabetic vitreous hemorrhage. We didn't see an exact source, but with fluorescein, as we go into the periphery, we can see this residual peripheral neovascularization, which we treated confluently and then treated the retina peripheral to it, and that we had long-term good hemostasis. Here we're peeling the membranes under fluorescein, and you can see that the membranes under fluorescein appear white, and underneath the tissue is dark. So you're really seeing excellent contrast. And so this was a surgery from Monday, and you can just really see the extent of the membranes. A lot of times we'll be dissecting membranes and we'll see the retina pool a few millimeters away, and the wispy edge of the membrane is sometimes hard to see, but under fluorescein you can really see most of the entire extent of the membrane, and we're just shaving it off. So we've seen several advantages. This is also, the last case is a choroidal neovascular membrane, which there's a submacular hemorrhage, and that was partially evacuated, and then we did fluorescent angiography to confirm that most of the membrane is temporal to fixation. So then we went ahead and removed it. Dr. Mishev is also doing some pioneering work on fluorescent angioscopy, where he's injecting dilute fluorescein into the vitreous to better visualize the vitreous and detect fluid coming from the subretinal space and retinal detachments. So, you know, the images are pretty, and it's really compelling to see in the operating room, but is it doing anything? So the first thing that we're doing, and this is along with Dr. Abro and Sosa in the Dominican, is we're looking at vitreous hemorrhage post-vitrectomy for diabetics. It's a 13 to 40% incidence, and the most common cause of vision loss following vitrectomy for diabetic eye disease. And since we're treating these areas of residual neovascularization and hotspots that we've not seen before, and since we're doing more targeted PRP, the question is, well, does that do anything? And so these are some early results, about 30 patients in each group with or without fluorescein. And if you look at the visual results preoperatively, similar 1.6 versus 1.7 or so, no p-value at 1 month. Intraoperative fluorescein patients are several lines better. Same thing at 2 months. At 3 months, the gap starts to close. If we look at vitreous hemorrhage, highly significant reduction in vitreous hemorrhage. Post-operatively, about 50% reduction in the fluorescein group. So these are early data and still retrospective, but I think it's pretty clear that something is going on, and that I think this modality is going to really be a new thing in our armamentarium to visualize and treat retinal vascular disease intraoperatively. So I'd like to thank everybody, and really appreciate the opportunity to be able to present. Again, this is my contact, and happy to talk with anybody or contact anybody after the meeting.
Thank you very much. Great presentation. I want to ask you, Dr. Alan Franklin, when you do vitrectomy and you see those new vessels, that the angio, as you said, creates a contrast for seeing better these membranes. And so how deep you go, and what if you got this bleeding? So how would you separate the bleeding from the contrast?
Not that I've ever nicked a vessel, but if you do nick a vessel, you see a plume of fluorescein coming up. And one thing that we do is we lower the pressure to begin with so that the fluorescein comes in. A lot of our sick diabetics, the fluorescein will kind of stay in the vasculature for longer than you would expect, but the patients that are healthier, it washes out after a few minutes. So we'll put the pressure, the intraocular pressure, back up to 60 after we get a good fluorescein signal. That tends to keep the fluorescein from leaking out and control bleeding, and it also keeps the fluorescein in the vessels, because there's not good vascular perfusion during that time, but it's only 10 minutes or so. and then we normalize the pressure and keep going during the surgery. Sometimes we'll inject 2.5 mLs of fluorescein to do the vascular peel, and then once we've peeled the vascularized epiretinal membrane, lose the signal, we'll inject it again to look for hot spots in areas of peripheral ischemia. So some patients we inject twice.
Yeah, okay, so you may do multiple injections during vitrectomy. This is very cool. Would you like to comment on this case, Dr. Frederic Matonti?
Yeah, do you hear me? Yeah. Okay, yeah. No, I just want to say that it's not so easy as Alan Franklin showed you with very nice picture, very nice video. It's a lot of work during the surgical sessions. He had a huge experience in this way, and that's why he reached very good results. But it's not so easy when you begin to use FA, intraoperative FA, to reach this kind of results very easily. So I'm working on too, and I try to adapt my ingenuity because it depends on the light source. It depends on what kind of light type do you use, wide field or a reduced field. It depends on the system, I mean steroids, constellation, whatever. And so you need to develop your proper setup, your proper parameters to be sure to have the best results. So I would like to thank again Alan Franklin for all his advices to permit me to develop the technique in my facilities.
Yeah, thank you. Vibhab, have you performed angio in your service in Delhi?
Yes, I haven't performed it yet, but it looks very promising, as Dr. Alan Franklin showed us. And as also I follow Dr. Lucan, the YouTube channel, so I keep seeing his intravitreal fluorescent staining. So I had a question for Dr. Lucan. What is the dosage that you use? Is it the same dye that you're using to stain the vitreous while doing vitrectomy?
The dye is the same, but the concentration is less than 0.1%. So you need to heavily dilute the fluorescein which comes from the vial, simply because you don't need so much. Later on I will show in my video that actually it's quite difficult to remove all the fluorescein from the eye if you use higher concentration, because it's 100% soluble in water. So you can imagine what will happen with full concentration of the fluorescein.
Yeah, very cool. Thanks a lot. And welcome Marcelo Sasamoto as well. Before I switch it to Dr. Lucan Michev, Gustavo would like to make any comments from Alan Franklin's presentation?
Hey guys, morning to everyone. So Alan is the one who is pushing this. I've been following him, and we did a publication on that on February or January, I'm not sure. And I'm trying to follow his steps, okay? He helped me a lot with that, with literature, with the filters. Then we abandoned the filters, exchanging the digital filters configuration. So I think this is a technology that it came to stay. Things like this Retinawesome talking about it, it's a good thing because we need to spread information. We need more people taking part on it, especially when we can already see his data about post-op hemorrhage. Everybody here who deals with proliferative retinopathy, we know that many times they bleed again after the surgery. So thanks to Alan and the whole community who has joined this idea. I think that we are on the right way.
Yeah, thanks a lot. Thanks, Gustavo, for your comments. And we want to spread the news for this new technology. And I think we're going to be pretty more interested on that. I myself planning to start in 2024 And I want to say hello to Dr. Hisanori Imai from Japan and Dr. Hiroko Yamada as well. Thanks for coming to the Retinawesome presentation. And I will leave it up to Dr. Luca Michev to present his case. And of course, his bio is so extensive, and also his contributions for these intraoperative FA are so good that I'm exempt of explaining more. And I leave it up to you, Dr. Michev.
Thank you, Hudson, and thank you, Alan, for inviting me to participate here and to present some of my work. This is a video of obviously advanced age-related macular degeneration, which just is a good example how well we can see all the vascular changes we might have in the fundus during the operation, because it was a case with hemophthalmos, so we were a bit in a dark what lies behind, and now we can see quite well, and the level of the contrast actually is amazing here, what is happening in the posterior pole. So at least if it doesn't change our surgical approach, we might explain to the patient next day after we clear the hemophthalmos what is the reason why he is not able to see like he wants to. On the other hand, we might assume that we can treat it with RTPA or anti-VEGF and things like that, and we have a basis for that, which is our intraoperative angio. This is another case where it was a hemophthalmos, long-standing one, and after we did clear the hemophthalmos, we did a fluorescent angio because on first glance in the posterior pole, there was nothing wrong. And we saw that it is a peripheral occlusive vasculitis with small points of leakage, as you might see. Also, you see interrupted vessel flow here, empty vessels. So we performed the intraoperative fluorescein guided endolaser, which makes the ingenuity not only visualization, but diagnostic and navigational system. So we are beginning to look a bit like the neurosurgeons, which I really like, actually. So what I want to say is that we might be better treating the retina and not damaging the healthy one. So here we have an advanced case of diabetic retinal disease. So you can appreciate the areas of the capillary dropout, and you can see quite well where the retina is perfused and where it is not. Of course, we can evaluate leakage areas and hotspots in the macula. So, as Alan said, it's all goes to your settings in order to see better the image. Here, this is a blood collection, something related to the question of Hudson. It is not a new blood, because if it was a new blood, it would be fluorescent stained. So here, this is a navigated endodiathermy, so we can see from where we might have a postoperative bleeding. So this is related to the study that Alan is performing now. So it is another useful thing. We can treat selectively where we have leakage, and it will lead probably to less postoperative bleeding in such diabetic eyes. On this case, it is another case of diabetic proliferative retinal disease, already cleaned. The membranes were cleaned. There is a leakage, of course, from the optic nerve. So leaking fresh blood is like fluorescent stained. You can see it here. And then in the far periphery, under fluoroscopic view, we can see quite well the areas where there is no perfusion, and we can treat them selectively with endolaser. So I think that it will definitely change the way we do a PRP, because we can actually save the retina that is still functional and to reduce the post-operative inflammation due to the excessive laser burns, because we have huge ischemia and then we have inflammation from the laser burns, and I don't think that this is better for the eye. So going more selective, I think it's always in a good way with the surgery, meaning that surgery is a synonym of precision. So if we are selective, we are more precise, and I do believe that we do a better job. So here we can identify even in the far periphery ischemic zones which with exolaser are not easily treated. So during the surgery, we might do a better job. So this is under chandelier, and it is quite safe, and it is quite useful in my opinion. And now you can see how the PRP looks like. So it is quite, let's say, forgiving for the retina. And next video, this is fluoroscopic visualization of vitreous. This is the normal view. And now you will see, this is a video from yesterday actually, and this is probably my last filter for fluoroscopic visualization, because there is one issue with the fluoroscopic visualization. Normally we see quite well the vitreous, but we don't see the underlying retina and structures of the eye, because we are using here, for example, excitation blue light. So rest of the spectrum is not there. And now you see here in this combination with digital filter and the excitation light, I see quite well even the hyaloid. I can see perfectly well the vitreous and the vitreous base, and it is done under chandelier illumination, so I can indent myself. Again, I work, I do believe, quite precise here. So you can see the stained vitreous, and for me the most important thing is that we can see the underlying retina. As Alan showed, cleaning the membranes which are stained will be even better if we are able to visualize better the underlying retina, so we can remove the membranes without possibly induce damage to the retina. So you can see again here how much vitreous is in the eye, and you can also see here the hyaloid, which is not well visible in a regular visualization. So this is cleaning the base. At least me, I started to do a fluoroscopic vitrectomy like 2 years ago, and from that time I was amazed how much vitreous is in the eye and how much we, let's say, believe in our abilities to see the invisible vitreous. And when the vitreous is visible, it is there, and it takes a bit more time. But I do believe that Mahemer called the vitrectomy a vitrectomy because we need to remove the vitreous from the eye. So, and this is a pure example how by seeing we are working better, because we are removing all the vitreous. I can see here again the hyaloid. So I think this is a beneficial also imaging modality, which is here to stay, as the fluoroscopic intraoperative fluorescein angioscopy. The fluoroscopic vitrectomy will be a game changer for how we are doing not only the diabetic case, but all cases in which we perform vitrectomy. And I think that's it. Thank you.
Thank you, Luca. Good visualization, good imaging, and how you use, I think you are an expert on choosing the right filter to go on with the vitrectomy. And so to start off, for people that are starting the cases, what would you suggest? What combination, as you said, what combination would be the best?
It's a tough question, actually. Either you need to have a good friend which will share this with you, or you need to press the industry, meaning Alcon in that case, to provide you with the settings, because it's not, let's say, a recipe that can be shared, and it is everything from the illumination source. It is, if it is a LED, xenon, halogen, from through the exciter filter, through the laser filter. For some of us which were in VitreoRetinal this year in Amsterdam, there was a good explanation why the laser filter actually suppresses the fluorescence of the image, because it's a 532 and the peak of the fluorescence is actually in between 530 to 540. So a lot of details are here, and I do believe that the industry needs to come up with a package solution from beginning to the end in order to more surgeons to adopt this new imaging technology. Because if you are given a wrong or suboptimal recipe, for example, you will have suboptimal images, and then you will say, okay, it's too cumbersome, it's not for me, the images are not so good, and you will give up otherwise a perfect idea, but not properly done.
Okay, thanks a lot. Dr. Hisanori, would you like to comment on Dr. Michev's cases? Dr. Hisanori is from Japan.
Thank you very much. Thank you very much for your great presentation about intraoperative staining of the vitreous by using the fluorescent. Okay, and I have one question. The visualization with the vitreous, usually we use the Retinawesome, right? So which is better for you?
So both are good or both are better, depending on which part of the vitreous you want to stain. Normally the particles of triamcinolone cover the surface of the vitreous, so it's absolutely indispensable in identifying the hyaloid or hyaloid schisis. The difference between the fluorescein and triamcinolone is that the fluorescein penetrates the vitreous and it not covers only the surface, but you can see, if I can put it like that, the stroma of the vitreous, so everything. And it's better for peripheral staining, in my opinion, or at least the application during the surgery is better visualization of the periphery. The triamcinolone is absolutely indispensable for bursa prima cuaris and this area.
Thank you. Great.
Thank you. Sasamoto, Marcelo, do you want to comment on the Michev's case?
Actually, I'm very impressed. It's a very interesting technique. I need to apply that. That's why this Retinawesome 21 is so important to me. I'm very interested in this in this process. I'm still learning, so I'm learning with you guys. So thank you very much.
Thanks. Athanasius, welcome. Good to see you, man. And so it's always good to see you smiling like that and having a good time in Greece. And please comment, is there any plan for the TVRS and adopting also the FA vitrectomy? No, we cannot listen to you. You are muted. Your microphone is still muted. Athanasius.
Question?
Oh, yeah.
Okay.
Oh, yeah.
I just want to say hello to everybody because it's becoming Retinawesome, become the Retina World Awesome. It's everybody there. Let's think about TVRS, the Retina Summer School this year, the first week of July. The important is that Alan Franklin is one of the organizers. So we cannot escape fluorescent angiography any more than you can do. So it's going to be taught by the master. So Alan is going to be there, and we'll see how the interaction is going to go.
Thanks a lot, Athanasios. Dr. Ahmed, do you have your case handy? Do you want to?
Yes, but I want to ask a question to Lucan about injection of the fluorescein intravitreal to see the vitreous. So staining by triamcinolone is very useful in determining if there is a posterior hyaloid still attached or not. Is the fluorescein handy in the same way, or seeing the stroma only and is useful for removing the vitreous, not visualizing the posterior hyaloid?
I think that the fluorescein is quite weak in staining the hyaloid. You can guess the hyaloid by the remnant vitreous above it, but what I see normally is that the triamcinolone is far better for hyaloid compared to the fluorescein. Fluorescein is good for peripheral vitreous and
the bulk of the vitreous.
Yeah, but not for the interface, let's say. Yeah.
Thanks, Ahmed. Before you show your case, VibeHab is asking about the fluorescent in the subretinal space. Is that toxic? Could that happen? You know, would anything be done to avoid it, Lucan?
No, you don't need to avoid it, because normally, even with ambulatory settings, when you are giving it intravenously, and in diabetic cases where you have a leakage, you have intraretinal leakage and supraretinal one. Also, it's not something new on our field. It was used first in Japan, I think in 1970s somewhere, to stain vitreous during ROP surgeries. And the problem is that at that time there were no wide field viewing systems, so it was 30-degree vitrectomy, exactly where the fluorescein is not so good. The fluorescein is good in the periphery, actually. So the profile of safety of the fluorescein is well established in ophthalmology, and it's not a concern, I think.
I also think that the fluorescein, when it comes through the choroid, it actually pulls under the retina. It's a normal thing. So I don't think it's of a safety concern.
Okay. Thank you very much, Lucan, for your cases and great discussions. Ahmed, would you like to present your case as well?
Yes, okay. So is it on?
Yeah, it's okay.
Yeah, okay. So with any new technology, we ask ourselves, is it useful? Will it be of instrumental use during the surgery? So I've gathered some of the cases where the intraoperative fluorescein angiography actually had an effect on my surgical decision. So the rebleeds, as Dr. Alan mentioned, this is a case of multiple rebleeds post-operative, and as you can see, there is extensive PRP, but during the indentation, and this is actually one of the advantages of intraoperative fluorescein, that you can do self-indentation and see up to the oris aorta and find the place where the leakage is or the new vessels are, and that's where I found the probable cause of the recurrent bleeds, inferior and superior, and I use that to target my laser. Also, that's another case with sub-retinal hemorrhage, with sub-ILM hemorrhage, where I couldn't see the cause of the sub-retinal hemorrhage. And as you can see, there is a lesion subfoveal that I couldn't decide if this is a CMV or the lesion in the inferior arcade, near the inferior arcade, where it looks like a macroaneurysm. So performing intraoperative fluorescein angiography actually made a difference, where I saw that the actual cause of the subretinal hemorrhage was the macroaneurysm, and I didn't have to inject the anti-VEGF. Also, it is very instrumental in pediatric cases, and I do some of the pediatric cases. So this is Coats disease with which is very advanced. We used a special technique to remove most of the subretinal fluid, and as you can see, the retina is actually laid back, and there are and it's actually almost flat. And then we performed the fluorescein angiography, and as you can see, there is a choroidal subretinal pooling of the fluorescein. That's why it's normal actually. So as you can see, at the temporal part, there is the abnormal vasculature, which is pathognomonic of Coats disease. And here we can see the pathology spreading on the temporal part, and here we can see very clearly where we could do either laser or cryotherapy, and that's what we did targeted at the areas where the abnormal vasculature was. And as you can see in the color. In the colored vision, the normal intraoperative vision, you cannot see very clearly as the fluorescein view. And lastly, that's a mystery case that was actually a week ago. That's a 2-month-old baby with a very dense vitreous hemorrhage. Actually, it is the cutter is having a difficult time cutting it, owing to the organized hemorrhage and the density of the vitreous in an infant. And after clearing the view, as you can see, there are some exudates, some vascular abnormalities, and some subretinal hemorrhage. That's actually, we were thinking that's a very early case of Coats disease, but I think it when using the intraoperative fluorescein and when seeing the actual picture, we were thinking about other options. So that's what that's my newest filter, and as you can see, there are some areas of capillary non-perfusion, and there is a arteriovenous anastomosis. Here I'm going through the veins and the arteries to see if it is actually an arteriovenous anastomosis, and also an area of capillary non-perfusion and some microaneurysms and vascular abnormalities. We were thinking about the cause, and so we waited for the late phase. Here I'm just checking the areas where the vasculature stops, and as you can see, there is leakage of in the macula and leakage on the disc, and here coming for the late phase. And as you can see, if I want to see something better, I approximate the light and the fluorescein, and the fluorescence actually is visualized better. And here you can see the area where the anastomosis is leaking, and maybe this is the cause of the hemorrhage as well. And at the periphery also, we can see areas of like a CFAM pathology and areas of capillary non-perfusion, also with the indentation. Actually, if we could do fluorescein angiography for the baby, we couldn't reach this far periphery with red cam or even with Optus, because the baby fixation would be very difficult. So we can see here the far periphery and the areas of non-perfusion. With this case, I couldn't do the laser because of the subretinal hemorrhage. So because it could lead to a surge of power and cause complications. So I just injected anti-VEGF, and we took some blood tests, and it was actually a rising high titer of IgG for CMV. And actually this, a similar case was, just one case was reported in the literature, and the baby was otherwise asymptomatic, and this is actually less than 1% of the cases. So I have other cases, but I don't want to take your time, so thank you.
Thanks a lot, Ahmed. Cool cases, good visualization as well. And Natarajan is asking, in the second Coats disease, did you do external subretinal fluid drainage and also vitrectomy?
Yes. Our technique is, actually it's not our technique, it was published before. So we actually introduced an intracath intravenous catheter, a very small one, the violet one, into the subretinal space, so as to drain transclerally. But before that, we introduce an infusion cannula and raise the pressure a lot, so as to drain the subretinal fluid, most of it, and actually works every time.
Okay.
Do you do a vitrectomy also?
Usually not. Maybe some core vitrectomy if I want to, if there is something that I want to remove, but usually not. I just visualize inside from the same port and do cryotherapy. Sometimes I do vitrectomy with laser if I see that it's fitting.
Okay, but I usually do cryo, and I also give intravitreal anti-VEGF.
We do also, yeah. We actually published a paper about it, yeah. Thank you.
Okay, good. Thank you. Very good cases.
Sorry.
Thank you, thank you.
Congratulations, Ahmed, on this last case. I never saw it like that. That's the beauty of this technology.
Me neither, yeah.
It changes the way you see the physiopathology of some diseases, and I never saw something like you have shown in the last case. Congratulations.
I actually wanted to ask you about if you saw something like that before. I'm still researching it. I'm not that sure. The baby is scheduled to take an echo step to do PCR for the CMV, so I'm not still sure that it's CMV.
Sure. Let's hear from the others, because I have no experience with pediatrics VR cases.
Yeah.
All right, and Gustavo, do you have your case handy? Do you want to be the next one to present?
Oh, you are the ruler, Hudson. You say, I obey.
Okay.
Let me just find the archive here. So this is a presentation. It's a short video. It has 3 minutes. 1 second. Let me just open here. And this is something I had. 1 second, sorry. My computer is a little bit. Now, yes. This is, let me share the screen here. Share screen, share screen. Can you see it?
Yeah, yeah. Full screen.
So this is a case we have presented a year ago during the VitreoRetinal in Rome, and it was when we started with Alan to develop the technique, okay? And I'll give a pause here. One of the things you're gonna see that the right eye and the left eye are different, because on purpose we left the barrier filter in just one of the optics of the camera of the Angiography. So you can see on the right side it's much more bright because we are not filtering most of the light. But on the other hand, on those times we were still learning about it, you're gonna have a better contrast, okay? And this is the one I think that nowadays it's the best solution for these cases, the black and white filter. You can see the ischemic areas, you have that aneurysma there, and we were just trying. As it was mentioned before, I think by Lucan, you need someone with the keyboard controlling it and someone that understands it. Otherwise, you will lose a lot of it. You can see on the left side, as I said, there is more contrast, but you lose a lot of images, okay? Some things you cannot see properly. So that's why the idea, and here you can see the leakage. As I was talking to Ahmed, I think it helped us understand the physiopathology of the proliferative disease much better, and why these patients have different cataracts when they are diabetic, because you have all those inflammatory and cytokines attacking the posterior part of the lens, okay? One of the things that I like from the barrier filter, especially when you have microaneurysma or some smaller stuff, you can see it with a better resolution because you are enhancing the contrast. With the newer filters, the digital filters, sorry, we can see it better, just like here, okay? On the left side, it isn't that clear, or the definition, I would say, like in the edema, it is not the same. And here we are playing, looking for different color spectrum, okay? This is the original green one. This is a patient which wasn't that bad as the other one, but full of ischemic areas, hemorrhage, microaneurysms. And we had, in these cases, I had my two brothers. One does glaucoma and the other cornea, and they said, no, we are not taking part on retina cases. Yes, today you will. So we were playing and looking which would show us better. Like in this case, you're gonna see to the macular edema can be better seen with some orange filters, and green gives us a better perspective. And this is also something nice about the Ingenuity. We can adapt it to our needs, our microscope, whatever we have. And since each one of us sees the colors in a different way, it will help us a lot. I don't know if you can see it the same way I see here, because in Zoom we lose a lot of quality when making the transmission. So the thing here is you have to take your time, you have to take one case to try to find a way, like here, the edema in orange, okay, better than in the other cases. And coming back, you have to take your time to try to find what works for you. Talk to colleagues, exchange idea, exchange parameters. I have done this, I have done that, and try to find what suits you better. And that's it, guys, and I'm happy to see that this has gone as far as we can hear. One of the, let me stop I have stopped, perfect. So one of the things, there are many things that we still don't know what we can do with this technology so far. I think we are doing just like people who do personalized refractive surgery. We are just burning the areas which are need to burn. We don't need to destroy a whole retina. Just treat the ill parts of it. And this is the future. Each time this is a personalized treatment. We are improving, targeting just the areas which need to be treated and not do a treat. I think in a short term, we're going to say that pan-photocoagulation is bad medicine. It's not done properly. That's it. Thank you, guys.
Thank you. Thank you. Good cases. And a great experience that you already have. And Nassim Abreu, Dr. Nass, Would you like to comment on the doctor's Hanning case? Nassim Abreu is from Dominican Republic. I think he is around. But
yes. Good morning, everybody.
Welcome, welcome to Retinawesome, the first time.
Thank you for having me here, and thank you, Alan, for the invitation too. I think that Gustavo showed good features of FA, where you definitely can optimize better viewing with digital filters on one side, and the something that I've always said that and that he commented on is that we all see colors different. So even though we can have much better contrast on black and white, which is a theoretical approach to it, we can definitely have different sceneries because of the amount of pigment that we have on an eye, where we can see a little bit better with different kind of filters and different colors on filters. So I think that this is something that we should look on in the near future. And in my experience is that for black and white, I haven't had that good of an experience because I only use a constellation light source. For me, it's always a lot more grainier images than what we can see on Lucan's videos, which are very crisp and bright. I know he uses different light sources, but I don't know why with my light sources, I do not have that crisp images like he does. So, great cases, Gustavo.
Thank you so much, Nassim. Sorry.
Yeah. So regarding the color perception, Gustavo is absolutely right, and that is why I think that staying with black and white will be more universal, because my red is not the same as Nassim or Gustavo or the red of Alan Franklin, for example. So black and white is not actually the real color, because with the digital filter recipe, we need to catch the fluorescence, which is roughly 530/40. And then we need to suppress the rest of the image and to turn it around to be black and white. And that is why probably it's a matter of optimization of the digital recipe and, of course, the light source. I'm using constellation light source, but with a new light bulb. I said that before. The new light bulb is mandatory because the intensity of the light and the light spectrum is a bit different than 300 hours light bulb. So it makes a big difference, at least in my testing, because we have 2 constellation machines with 4 illumination sources. Trust me, the 4 of them are different if you do a spectroscopic analysis of the light and also the light intensity. So fine-tuning all the links in the chain will bring you the best image.
I've noticed too that some of your videos where you have a very good black and white image do not have the light bulb on. Like we don't see the settings on the video. That's why I was guessing that you were using another light source on like I was just
yeah, you're right, but I experimented with a lot of light sources, and that is why I have the spectral curves of at least 5 of them. So you're right, in some of my videos there is no light on.
So I have a question for
sorry, Ahmed. And I know that you have worked on this a lot too. Maybe you could comment on this. I know that the type of filter that you put on the light source does influence on this on the quality of the image too. I don't know if you can comment maybe on the quality of the filter itself. What could we do to optimize this image when we are going to FIA?
When you dig a little bit deeper in the manufacturers of filters, the name Semrock pops up. You have Edmond Optics, you have Semrock, you have Omega, you have Optolong, you have a lot of them. But Semrock, they have a bright line of products, meaning that their optical density in the band pass area is absolutely amazing, and they suppress less light, meaning that they maintain more of your light intensity of your light source. For me, nowadays, a xenon light source is the choice. The LED ones, I somehow didn't manage to get a good image or good light intensity with them, so I abandoned them. There are other issues with the LED, especially in terms of phototoxicity. So xenon light with Semrock bright line 485 nanometers is my filter of choice. Edmond Optics, they have a good ones. Omega, yeah.
And I get good images, but I don't like the black and white I get from them. I know it's not only the filter.
You're using the digital pseudo barrier filter, not hardware one, right?
Yes.
Because in my opinion, the optical barrier filter is a trade-off in terms of light intensity and overall image quality, because it suppresses rest of the, it's a notch filter or a band pass filter, right? Let's say only 540, and that's it. Less of the image is gone. So, yeah.
Okay, thanks, Nassim. Nassim Abreu, do you have a video to present?
Just a small comment before Nassim, sorry. I think that the word recipe is the best one, because it's just like cooking. If you use different ingredients, you'll have a different final plate.
So about?
Yeah, I agree with, sorry for the background noise. I agree completely with Gustavo. You have to optimize your settings in the OR, and I find if my settings aren't optimized, the algorithms and the digital viewing will start giving you noise, and that's the grainy images or video feed that you're seeing, Nas. So we've just kind of refined, and it's working better now.
Yeah.
And to Lucan's point, I think that's where industry has to come in and has to be able to provide good solutions to our colleagues to make it easier for them to get good imaging during surgery.
So I have a question for everyone, actually. So I feel there's a much appreciation and thanks to extend to all the group. Everyone helped me with the fluorescent. But actually, this FluoRetinal presentation by Gustavo was the first introduction for me to the fluorescent angiography. And it talked about the targeted laser instead of doing the PRP. And when using now when I'm using the intraoptic fluorescent angiography, and I'm seeing the parts where there is hyperperfusion or non-perfusion, I do PRP on them, but I actually do the pan-retinal photocoagulation still. So do you have any comparison between groups doing targeted laser or versus the PRP, and seeing if there is less or more post-operative bleeding for them?
Can I answer here?
Yeah.
I can say that I have done like 5 to 10 cases, and in order to do good navigational endolaser, you need to have a good image. Still, we are struggling with the image, so it is less likely to have a really huge number of cases which can be somehow interpreted in terms of which one is best or better. My feeling, let's say, is that when I don't destroy the healthy or the still perfused retina, I still provide more chances for this eye to function properly. And what I saw in these 10 cases is actually that they are doing quite well, but it's not enough data for, let's say, a randomized controlled trial or something like that. I don't think that any assumption or hypothesis at the beginning is based on a real world experience. We need to gather this experience, but in order this to happen in a large scale, again, we need a full solution, and we give you that. This is your fluorescent angio, and it works in all cases. Then more of us will start doing a selective endolaser therapy, and then we can compare our results with what we did in the past, which is PRP. So for the PRP, we don't need any guidance, we just laser everything.
I will add, Ahmed, another thing with that. I was going to say the same thing. We still have to establish how it really works, what's the best way. Okay, this is way everybody goes through here. Then in a midterm or long-term future, we'll have an arm of that study in the DRCR-net, for example. The thing is, the same thing, I feel better just burning it, but maybe we'll see in the future, and I think this is the best technology to help us. We need a safety margin, like for example, when you are going to do a biopsy, we have to go 1 or 2 millimeters further in the retina. This is the best way. I understand you about the PRP, and I think this is the most of our reality. This is the reality for most of us here. Socioeconomics. Patients in Brazil, in Egypt, it's more or less the same. They are poor. You burn the whole retina because you know they are not going to control their diabetes. You do just the ill areas, in half a year, 1 year, they'll come back bleeding again because they couldn't control it, because they don't have access to food, to insulin, or whatever. But I love the question. That's a big challenge.
Yeah, thank you.
Yes, it is challenging.
Sorry, Nassim.
Nassim, yeah, you're okay with your video?
Permission to share screen. Okay, I got it now. So we've seen many cases already. I would like to share a little bit of what we talked on retina, which was some of the safety profiles of the intraocular FA that maybe some might have questions on it, because we're dealing with blue light. We know that blue light is absorbed mainly on the cornea, the crystalline lens, and the retina. But inside this blue light spectrum that goes from 415 to around 500 to 515 nanometers, we could divide this into two blue light spectrums. The hazardous one that goes from 415 to around 455, and the less hazardous one, which is up to 515. And we know that the blue light interaction in the retina mainly gets absorbed by the photoreceptor outer segment, which produces the more oxidations at this point of the retina, which promotes an incomplete digestion of the oxidized photoreceptors outer segments by the RPE. So what this happens to do is that it starts to accumulate lipofuscin in the RPE, which contains the A2E, which is one of the most photosensitive products of the visual cycle that tends to get very excited with wavelengths that go from 435 to around 445, which is the most hazardous blue light spectrum that there is. So that's why we encapsulate this hazardous blue light spectrum up until 455. So this consequently generates reactive oxygen species, which ultimately degenerate the RPE cells. And we know this this is mainly a problem in patients with AMD, because with age, this process tends to exacerbate. So we've studied this before. This is mainly on rat, a different type of rat retinas where they get dark adapted and then excited by blue light, or blue light combined by green. On the left side, we can see that when these retinas get excited by blue light, hazardous blue light in this case, we stop seeing the definitions between the different layers. And if you look on the right side of the image, you can see that depending on the amount of time that they get exposed to blue light and the amount of time that passes afterwards, we get even more disorganization of the retinal layers. So I think we just talked about it. A2E is the main photosynthesizer, and it gets peaked at these kind of wavelengths. And we actually, like I said, we know that it mainly depends on the wavelengths and the exposure time that the retinal tissue gets excited by the blue light. So I have a couple of cases that we've done. Like I said, I haven't optimized my black and white digital filter. I like this gray and green filter because it gives me a lot more light to the video. I don't have to manipulate the video editing. And here we can see that this diabetic patient, we can see a lot of non-vascularized peripheral parts of the retina. We can see a severe macular edema, mainly on the papillomacular bundle, and we can see active neovascular leakage here in the inferior temporal arcade. I think that in diabetics, it's probably the main pathology that we can think of, that we can use it here. Like cases shown before, this was a patient that had vitreous hemorrhage, and we can actually intraoperatively diagnose a macular ischemia and talk to the patients the post-op day one and tell them on what their prognosis might be, depending on the degree of the macular ischemia. Another thing that we can assess correctly is the periphery. We know that peripheral ischemia during severe diabetic retinopathy can result in non-resolving macular edema. And so if for example we have to take these patients to the OR, we can treat it right away and see areas that we cannot miss on achieving PRP. And here we VR surgeons who treat severe PDR know that at some point we're going to encounter neovascularization where you get blood clots over the neovascularization. We cannot see if it's actually leaking or not. Well, with intraop FA, we can see that it leaks under it, and we can assure that we need to definitely either remove the blood and treat, or do photocoagulation over it until it stops leaking. These are another cases which I have found very useful intraop FA usage, which is a sickle cell disease that we have a lot here. This patient, we know that generally they do have a lot of peripheral ischemia, but they tend to have a very good vascularized posterior pulse and mid-periphery. So what we don't actually know if we don't have the intraop FA is up to what point we have to go back into the retina, either up to the equator or either farther back, photocoagulating. This is a similar case to what Ahmed showed, where this patient had drusen and GA on the left eye, and this eye had an intraretinal sub-ILM and inferior and on subretinal heme, and we decided that with intraop FA was not CNV, and we just did we just took the blood out and no anti-VEGF was injected. This is a very pretty case of an ROP where we had some retinal detachment that we were not actually sure if it was retina or not. We could see some vessels coming up this kind of fibrous tissue, and after we cleaned up the blood and took that tissue out, we could see that we had some vascularized retina proliferating up under the tissue that we had already taken. So this was not apparent on normal visualization. So through intraop FA, we could actually delineate the area of ischemia and just treat the non-vascularized and perfused retina and leave the viable tissue without any laser treatment at all. And I think this is my last case. Thank you very much.
Nassim, such good cases, great imaging. And before we call, I would like to ask you some questions here from, actually some comments from Dr. Hizanori. He prefers to do target lasers. In your case, would you like target lasers as well? His personal impression is that there is less inflammation after surgery. But you did this laser so well, so I'm not sure about it. And would you like Dr. Hizanori to comment on his case? What do you think?
Sorry.
Nothing. Oh, yeah.
I guess mean whose case?
Yeah, I was kind of.
Okay, so you had a question that the target laser or retinal photocoagulation, which is better? You had a question, right? But by using the 3D FA, we can recognize the area of non-perfusion, right? And I think just do the laser to the non-perfusion area is enough. And I think do the pan photocoagulation in all cases is too much, I think. Sometimes we experience the severe post-operative inflammation, especially after the surgery for the PDR case, right? So I think the merit of one of the merit of 3DFA is we can decrease the number of the photocoagulation during the surgery.
So, Doctor, I want to comment on that. Do you only do targeted laser for PDR now that you're using intraop FA?
Yeah, when I use the 3D FA, I just do the targeted laser.
Because we know that there's been published data on half the fluence and dosing of spots on PDR,
Yeah.
but it had not been that successful, mainly because we're probably leaving non-perfusion areas without treatment because we're not seeing it. So are you mostly toward leaning just treating those or non-perfused areas and just watching them over time?
Yeah, actually, after the surgery, like 6 months, 6 months is or after the surgery, I performed the fluorescent angiography in the outpatient clinic, right? And if need, I add the pan-retinal photocoagulation at that time. We don't need to do the PRP during the surgery. I think we can do the photocoagulation later.
Okay, sounds good. Thank you.
Nas, I kind of do a little in between the protocols in terms of with our non-compliance. I will do a scatter laser in the better perfused retina because I've seen a handful of patients. This is pre-fluorescein, but when I was mainly confining the laser to the periphery and eyes that weren't all that ischemic, they come back 3 or 4 years later with NBG. So I'll laser heavily in the non-perfused retina, and then in the perfused retina, I'll do a scatter. It won't be very heavy, but at least I know I'm debulking the neovascular stimulus that may come in a couple years if I at least scatter in the laser, and hopefully I'm not affecting the visual field that much in that area.
Okay.
All right. Thank you very much, Dr. Nassim. I really appreciated your cases and imaging. Thanks a lot, and welcome again for being part of Retinawesome 21st. And je voudrais inviter maintenant Frédéric Matonte de la France, Marseille, une très belle ville. Thank you, Frédéric, for coming to this next meeting with us. Are you going to speak in French or English? I guess it's English, no?
I'm speaking English, yeah. So I just have to share my PowerPoint. Okay. So my case is a combined case because I would like to show the use of fluoroscopic angiography during the surgery and also a tricky and a challenging case. So I name my VitreoRetinal surgery. It's not a smooth ride. So this is a case of simple epiretinal membrane with nice post-op results operated by one of my fellow, nice structural and functional results. But if you look at the temporal part of the macula, the pinch, the initial pinch was a little bit too strong, a firm pinch, with a pigment epithelial trauma. And as you know that, it could lead to some complication as neovascularization. And this patient was referred me 3 months later with a huge decrease of visual acuity, disruption of outer retina with an infiltration of macular neovascularization. So the post-op first month result was good, but at the moment, the patient was a little bit disappointed, and my father too, and I was in trouble to have a good way to treat this patient. So classically, I initiate the treatment with anti-VEGF, and as you can see, after 4 monthly intravitreal injection, the results were very poor, with no really improvement of visual acuity, with disruption of outer retina, even if outer nuclear layer is still there. No ellipsoid zone visible, and external limiting membrane is disrupted too. So I check how to manage better this patient and how could I improve the results. So I discussed with some of my colleagues, and specifically with the holder with huge skills in terms of retinal surgery for neovascularization before the era of anti-VEGF. And I found in some publication, recent publication, in October and January 2023, some publication on the place of subretinal surgery. So it's sure it's not the first way, it's not a first-line treatment, but in some cases, complex cases, as in traumatic neovascularization, inflammatory neovascularization, we don't have choice because, as you see, the anti-VEGF are not effective on this kind of membrane. So I decided to operate the patient. This is the surgery. And I would like to show you the angiography. So it's not really useful, but the angiography is nice, and we could observe the same sequences in terms of filling of the vascular network. As you can see, we have a progressive filling of the membrane in the middle of the macula with a ring, hypofluorescent ring around the membrane with a staining, a diffusion, a mild diffusion of the new vessels and the feeder vessels on the temporal part of the macula. So I use subretinal tools, Thomas Pick, forceps, to dissect and to remove the neovascularization, and the angiography permit to check there is no remnant of neovascularization, no active leakage. You can see the IOP was 29 after the end of the surgery under fluid, and during the exchange, I increased a little bit the IOP to prevent a rebleeding. This is the result at 1 month. So the result is very poor in terms of function, but the structure is quite nice. So you can say, okay, it's not useful. It was completely mad, but I ask you to hear and to take not as a joke. This is a result at 7 months, 2025 low, and I saw this patient 2 days ago. I didn't have time to extract the OCT, but the visual acuity 10 months after the surgery was 2025 with no perception of sclerotoma, even if, as you can see on the temporal part of the macula, there is a large defect in RP due to the pinch and due to the dissection, but the benefit was and is huge. So we were lucky men, the patient and me. So this kind of surgery is not classic surgery, I confess, but all this kind of surgery in the past lead to develop and to have the basis for the new approaches of the treatment for dry and exudative AMD. I mean retinal prosthesis, as for Primavera, this the left example I implanted 1 year ago, for genetic therapy and probably in the future cell therapy. So I think we need keep going up our skills and not to forget this kind of technique that are tricky, yes, but sometimes could help us to reach better results for disparate patients. Thank you.
Well, that's a beautiful presentation and a great result. I have done a couple of these, the last video that I've shown, and I'm anxious to see my results. Hopefully they'll be close to as good as yours. But I think that when you did the fluorescein during the case, did you do 2 injections, one pre-dissection and one post-dissection?
Yeah, exactly. It's necessary to re-inject, to refill after the surgery, because the dissection takes about 20 minutes. So during this time, the washout lead to no fluorescein in the macula. So I re-inject 1 milliliters at the end of the surgery, and so you could observe a nice fluoroscopy, and to be sure there is no leakage, because I was afraid by the leakage with active bleeding, and I would like to check if there's, if I didn't remove the RPE with window effect or other phenomenons.
No, I think that's great, and you know, we're doing 2.5 mLs, and then if we need to re-inject, we inject another 2.5, so total of 500 milligrams. Is that about what you were doing, or were you doing a little more?
Yeah, for the first injection, I usually inject 2 milliliters, and when I have to re-inject, I prefer to decrease the dose, mainly between 1 and 2 milliliters. But it depends on the weight of the patients too, and the kidney function, etc.
Well, thank you again.
Thank you too for the invitation, and thank you, Edson, too.
Thank you, merci bien. Our next presenter is Dr. Imai, who really pioneered this technology. Had the opportunity to see Dr. Imai present a few times, and his depth of thought and how he figured this out in the first place is just wonderful. So we'll turn the podium over, the virtual podium over to Dr. Imai, and thank you.
Okay, my turn.
Yes.
Okay, so thank you very much. So my name is Imai. Hello, everybody. I work at Kobe University in Japan, and thank you very much for giving me the opportunity to speak at this web conference today. And I was very impressed by everyone's excellent presentations. And today I created a presentation video to explain the basic concept of this new technique. I think the most important point of this new technique is how to perform the color enhancement. And actually, I love black and white image. So let me start my presentation video. Professor Nakamura, could you please start my presentation video on your computer? Is it okay?
Just for the record, I'm not against black and white. I just haven't had the chance to get good images, but I'm working on it.
So can you watch my video on your screen? Everybody know? So, Professor Nakamura, could you please?
I see your screen. Yeah, it's not.
You can see.
You cannot see it. I see it. Yeah, you just turn play on. And are we able to see it now?
Is it my presentation video started? No? Not yet.
No, it's on pause, but I see here. It's not on yet. Now starting. FA screen, but it doesn't seem to be moving. Now it's moving, but
no, it was okay. It was playing. Just the initial slide was longer. It was okay.
But if you, Dr. Imai, if you want to send me now by email, I can download it and pass it.
I think I send the email for you today.
If I may interrupt, if it is a video, Hudson, it will take too long.
Oh, yeah, sorry.
I think our friend, our Tomodachi, Imai, was doing fine.
Okay, but still, if you want me to play it, I will write the email. Yeah, I think now we're going to be able to share it. I see your screen.
On my screen?
Yeah.
Okay. And which part?
In the middle of the screen, you had the Retinawesome. Yeah. Perfect.
Okay.
Oh, that's cool. Let's see if it moves.
We can see it's going. On the left lower side is the seconds and they are passing. Sorry.
We don't have any audio, or I don't, but I can see it going.
No audio.
No,
Does anybody else have audio?
No.
No, no audio.
No audio. Wow.
Sometimes if you hear audio, Dr. Imai, but we're not, you can go to your Zoom settings and look at the audio in the Zoom settings. Sometimes that.
Okay.
No, when you click on share screen, on the right lower side of the window, there is a small thing to check that you want to share your audio. You have to stop sharing and start sharing screen again.
Okay.
And then you click on those two buttons. That one is share video and share screen. I mean share audio as well.
Audio.
How about this one?
You open the Zoom, you open the screen share. It's at the bottom. You share. You check the two boxes.
We can hear you, but we need to. We still don't know if we can hear your audio from the presentation. You need to share again.
You cannot hear.
Yes, we can, but not
really?
the presentation.
Why?
But anyways, we could have somebody else present while you send me the video. You can. I sent you a message. You send me the video, and I play it from here.
Dr. Imai, before you start, just click on share screen, then you have a new window, okay?
Yes, screen, yes.
Okay, now on left lower side of this new,
okay.
You have share sound, okay?
Okay.
You click there and then you click on share.
Okay. So now
you can play the video. We will have the sound, probably.
So my name How about this?
Yes, now yes.
Perfect,
Okay.
perfect.
Thank you for this great opportunity to share.
Do it, Ashma.
I will give the uses of intraoperative fluorescent angiography in vitrectomy. As you know, vitrectomy has advanced significantly, and one of the current hot topic is heads-up surgery. There is much debate about its benefit, but I believe its key advantage is the digital enhancement of the surgical view, which is not possible with traditional microscope. Currently, there are no definitive settings for enhancing the visibility of the intraocular tissue using heads-up surgery. Therefore, it is crucial to understand the three color property: hue, brightness, and saturation when thinking about how to digitally adjust color settings to improve the visibility of the target tissue. For example, placing colors with different hues, particularly complementary colors like red and green, next to each other is an effective way to enhance their visibility. It is also effective to arrange colors with different levels of brightness within the same hue, such as bright red and dark red. Furthermore, reducing the saturation of colors in the image can help create a high contrast black and white image, further improving visibility. For example, if the original surgical view primarily consists of bright red and dark red, you can transform it into a white and nearly black image by decreasing the saturation. With heads-up surgery, you have the capability to adjust the three color property mentioned above. Additionally, digital filter can be quite useful. Think of digital filters as applying a colored transparent layer over the surgical view. For example, placing a red filter on the red text makes the text blend into the background. Conversely, if you overlay that red filters on green text, the opposite effect occurs. The green turns black. This simple concept is essential for enhancing the visibility of a specific target tissue. Recently, we reported that the visibility of ICG-stained ILM was statistically better on a monochrome surgical image with a red color digital filter compared to the normal color surgical view. By applying a red color digital filter, the color of the surgical view can shift to the almost red hue. The green color caused by ICG staining can transform into almost black with the red filter. Subsequently, by decreasing the saturation, the red changed to white and the black remains black. This resulted in a high contrast black and white image. So we compared the visibility of ILM between normal color surgical image from conventional microscope, color image from DAB, and monochrome image under red, blue, and green digital filter. As a result, both objective and subjective evaluations showed that the visibility of ILM in monochrome image under the red digital filter was significantly better than others. This is a representative case of this study. The visual acuity at the first visit was 0.8. After the vitreous shaving and ERM peeling, the ILM was stained with ICZ. The fundus was observed on color and monochrome image under blue, green, and red channel. ILM peeling was first performed under color image and then completed on monochrome image under the red channel. We can recognize that the visibility of ILM is high in monochrome image under the red channel. 3 months after the surgery, there were no complications and visual acuity had improved 1.2. So by now, you should be able to understand the potential of color enhancement by using heads-up surgery. 3D fluorescent angiography, the main topic of today, is also one of the techniques that enhance the surgical view through color adjustment. We applied this technique to PDR patients with vitreous hemorrhage. Usually, these patients cannot take adequate image analysis, including fluorescent angiography and OCT, before surgery to determine retinal status and plan surgery. This technique is very suitable for patients under such a condition. In the original paper, we installed both a blocking filter and an excitation filter on the surgical microscope and light source, respectively. In particular, the use of blocking filter allows us to emphasize only the bright green color of the fluorescent dye against a black background. Subsequently, by reducing the saturation after applying a green digital filter, we can attain a high contrast black and white angiographic image. So this is a case involving vitreous hemorrhage secondary to old retinal vein occlusion. As you can see, we can obtain a very clear contrast enhanced image by using this technique. The advantage of this technique is that we can perform the surgery with an angiographic surgical view. This allows us to identify abnormalities on the retinal surface that may not be visible under normal color surgical view. We can accurately determine the location and extent of active fibrobascular membrane. By conducting membrane segmentation and delamination within the angiographic view, we can effectively remove the membrane. We can also precisely locate the area of non-perfusion, enabling us to perform photocoagulation as needed, contributing to the minimal invasive surgery. So I think this is a significant advantage for many vitreous surgeons. This is another case. As you can see, it's a severe case of PDR with extensive fibrobascular proliferation and tractional retinal detachment. For this case as well, we introduced vitreous surgery combined with 3D fluorescent angiography. As you can see, we can accurately assess the location, extent, and the activity of the proliferative membrane. The widespread area of non-perfusion are also clearly depicted. In this case, we further employed intraoperative OCT to safely manage the proliferative membrane. This demonstrates how image processing using heads-up surgery holds great potential even in the future digital age of vitreous surgery. Here is a post-operative fundus photograph for this case, and the post-operative progress has been excellent. So today we discussed the utility of intraoperative fluorescent angiography using heads-up surgery. We consider this technique as just one example of the possibility in the field of digital surgery. We believe the potential of digital surgery, including this technique, is vast, and we encourage you to explore it if you are interested. That concludes my presentation. Thank you. Very much.
Thank you, Dr. Imai. Beautiful images. I love the way you peel those membranes. And do you use a special forceps for that? And how do you like by manual technique? Because you see the retina is elevated. It's a proliferative diabetic retinopathy case, very tough. And how do you approach? And then you switch back to angio to see whether you got the vessels or the ischemic areas.
Actually, as you said, the last case was very hard case. So we need to use the bimanual technique and indentation with the eye both. But actually, I can check the activity of the fibrovascular membrane by using the fluorescent angiography, and I determine the position or extent of the fibrovascular membrane during surgery. But in this case, I used the intraoperative OCT. By using the OCT, we can check the position of the epicenter of the membrane, and I can select the starting point of my surgery. By using both 3D FA and the intraoperative OCT, we can perform the surgery very safe. Yeah, we need a longer time, but the surgery is safer, I think.
Yeah, I think so too. And anybody would like to comment? Dr. Alan Franklin would like to comment on Himai's case?
I mean, he's done beautiful work, and you know, the first time that I saw it presented, it was really transformational, both in terms of seeing the vascular epiretinal membranes during the surgery, seeing the anatomy during the surgery, and then the fluorescein guided surgical manipulations that he was doing. So it's just really nice work, and I really appreciate his contribution.
Yeah. I want to comment on something. I found very, very useful your explanation of the color series, and so because you use ICG, you would enhance the red filter, and
Yes.
then take out all of the saturation, so you can get that enhanced contrast under black and white, right?
Yes.
For us that use blue dyes, then we would have to use the yellow filter to kind of get.
Yes. Theoretically, yes.
Okay, so I'm just putting up the pieces together.
And one point, I think the visibility of the tissue is better in black and white image compared to the color image. My results suggest that the visibility of the white and black and white image is better. So that's the reason why I love black and white image. Okay.
I think I tried once your recipe for the intra-op FA. I have to go back again and take a look at the parameters, but I remember that I had a lot of a very grainy image, and even when using the chandelier and the straight light, But I'll have to go back again and check on what I did and see if I'm correct on my parameters and try to enhance that again. Thank you.
Thank you.
Thank you. One more comment, Ahmed Habib. How do you approach as compared to Himai's technique?
So I've tried. Me too. I also like the black and white image, but I've tried to obtain it with no avail, actually, with no success. The closest I've been to performing to obtaining the black on white, that I increased the green color and decreased the saturation. So it gives me black and white, but with the green color of the fluorescent. I've tried the monochrome, and it didn't work actually. I'm not sure why, but I will try to increase the green, right, and do the monochrome. Is that what you're suggesting, Dr. Amir? Are you suggesting that to increase the green color and switch on the monochrome filter? That's how you get the black and white?
On the 3D FA?
Yeah.
Yeah, on 3D FA, the really important point is that we usually use the blocking filter, right?
Okay.
So by using the blocking filter, we can watch only green color, and the background is totally black. Okay. So when we inject the fluorescent dye, we can only watch the fluorescent from the dye. It means a very bright green color. And the background black. So at that time, we can get a very high contrast image. It means the bright green and bright dark green. It means black, right?
Okay.
So at that time, we only get a very good contrast image, but still, after that, by decreasing saturation, we can get the more better high contrast image. It means the black and white image.
Okay, so you decrease. So you only increase the green and the red, green, blue dials on the Angiography, then
Actually,
decrease the saturation.
Not increase the. You mean the put the green digital filter, right?
Yes.
Yes. Just put the green color filter and decrease the saturation. Yes.
Decrease the. Okay, I'll try it. But it's still not that bright as, for example, as Luke and showed it. It is. Yes, it is actually black and white, but it's not that bright. Should I increase the brightness, for example?
No, actually not. In the original paper, I increased the brightness or gain or iris slider.
Yeah.
I increased, but actually we don't need it. We can do the 3D effect by using the same setting as usual.
I think, Ahmed, that the like I asked Luke, and the quality of the filter is key, and I do believe that the best images that we see from I'm not sure if Dr. Imai only uses constellation light sources, but I know from Lucan, the brightest images that we get, it's not from constellation, it's from another light source.
Yes, I use the photon from the synergetic.
I think that it's that's a better option right now for intraop FA.
Yeah.
Okay.
To put the filter in the constellation is very difficult. It's up to the version of the constellation, right? So older version we can put the filter in the constellation, but newer one, new constellation.
The newer one actually it doesn't have the holder, but it
Yes.
has the slot where the holder fits in, so you can get it from
Oh, yeah.
a friend or so. Yeah.
Thank you.
Yeah, thank you very much, Dr. Imai. And I think we are done for the FA meeting. Dr. Alan Franklin would like to close it and wrap it off so that we could present maybe a couple of cases in the regular vitreoretinal surgery to end the meeting. And would like to say anything for this first Retinawesome meeting on angio?
Well, I think it was a great discussion and a great faculty. I really appreciate all of Dr. Nakamura's efforts to put this together, and it's hopefully something that we can do again once we've made refinements in the technique and hopefully get more adoptions. But having these meetings and this sort of interchange and exposure, I think, is great, both to refine what we're doing and to get more people doing it, which is critically important. So thank you again.
Yeah, thank you very much. And Athanasius, so we'll probably share a couple of cases. Do you have a regular vitreoretinal surgery case to share with us?
Yes, I think I can. Nice to go back to normality and reality. It looked a little bit like science fiction to me, playing with colors, because every one of us have a different peak in their color image. So the next step to my idea is that next to the colors that we see, we have to detect the special peak of each surgeon's color line, which is his peak, in order to promote that, in order to enhance his personal peak. So we're going deeper and deeper into the color game and getting thinner and thinner. But I love that, what you're doing, and I will try to share something that it's more, let's share screen first. And I would like to do this. I don't know if you can see it.
Yeah, you can see it.
I got a short video here. It's a lady who just was refused to be done surgery to her because she had uveitis, retinal detachment, and also cataract. And that was 6 months ago. And that after 6 or 7 months, people say that there was no actually perception of light, so it's a not operable case. So we're going back to say which is inoperable and which is not. And I don't know if I can share it. You let me end the full screen. First of all, we got to see what's going to happen with the cataract. So we just use the iris retractors, and we try to put the 25 gauge trocars. In this case, I'm not using valve trocars because you'll see later. And I'm finishing the phaco surgery while I have implanted all the trocars inside the eye first. And then I have to see what's going on with retina. And then you can see there's a PVR in the retina, that's normal. And then I put a light because I need 2 hands for that. And we're going to the multiple way of, that was the reason that she has refused the surgery. It was that there was too much peripheral PVR, which is the most difficult, that needed scleral pressure and needed also, and then I tried to drain to find locate the tear. And you can see with the scleral pressure, that's another take-home message. You can detect the tear, and then we tried to use some PFCL. And now that's the first time I'm showing to you. This is an infusion setup from the infusion using silicone oil 5700 centistoke by using an old M1 infusion line, which is can be pressurized, and using the bimanual way of the constellation, removing the perfluorocarbon and injecting silicone oil at the same time through the infusion line. And what is so special about this infusion Med1 line? The infusion is that it doesn't matter how much pressure you're going to put in, you can see it doesn't come off because it's plastic on plastic, covering plastic. Silicone oil loves metal, so you can see even if you clog it, it doesn't come off the trocar. So it was an ingenious made by Med1 that nobody's using anymore because they're using the other systems, but I love to have it, and I love to keep these things on my table and having a complicated case. As a matter of fact, after the surgery, the lady recovered some light just between 140 and 120 with this eye, but the other eye was good, and she was very happy with it, but just having the light was not enough. And after a couple of years, she had an injury in the good eye, and she got blind to the good eye because she had multiple retinal detachments and been operated several times. It was not in Greece, it was in another country. And she lost her eye. So this eye that was critically inoperable, nobody wanted to take off, nobody wanted to try it. That is the eye that she's using to live for the last few years. And so the take-home message is never give up, and we do surgery to almost all of the eyes that they need to, despite the LPs and the long time and the 6-month surgery and how complicated it can be. You never know what is going to happen to the other eye. You never know what is going to happen with this. So under the guidance of my old teacher, Relio Zivojnovic, who is happily living now in Montenegro, never give up. Thank you very much for this opportunity to give you some of my videos, sharing with you.
Thanks, Athanasios. Loved your technique. And let me ask you, I like doing that. Actually, my last case was yesterday. I did the direct PFC silicone oil exchange. It was at 500, over 5,000 centistokes silicone oil, very dense. And so what I did, I was doing the direct exchange. I keep looking at the optic nerve. I see it like beating. You see the vessels there, and sometimes you get a very high intraocular pressure. And what I like to do is to stop at this time and to get, as Ahmed Salam suggested in the last Retinawesome meeting, that we could open up the backflush cannula to get the PFC out a little more and get a larger cannula, maybe 23, because 23 is better than 25 in this case, and so that you would curb the situation of getting this high intraocular pressure. On the top of that, in this case yesterday, because the pressure was high, I opened up a bit the drainage site for the backflush cannula, and so some of the oil escaped, and the oil stayed in all retina because we had PFC from the pars plana down. So the case was completely cool without raising intraocular pressure at the end. So what do you do to curb the situation of getting high intraocular pressure in high density silicone oil?
I'm using the Constellation system, and I'm using the dual foot injection pedal they have. If you put this dual injection in your Constellation system, and you got a light pipe, so that means that you have two-hand surgery, you got a chandelier light. From one hand, you inject silicone oil, and with the other hand, you have your hand with a fluid needle removing energetically, not passively, energetically, the PFCL. The thing is, when you have half of the petal pressed, it's only injecting silicone oil. When you have all the petal pressed down, you have injecting silicone oil and removing PFCL. So you can control it all the time like driving a car. You inject a little bit if it's soft, you stop injecting if it's flat, and you remove some PFCL. But you're doing constantly in the same setup, and you don't need to go back and forth 23, 24, whatever. You just use, but the problem with the system and the companies is that, and that's what we're doing in TVRS with your guidance in Thessaloniki in the summer school. We give them tips like that nobody's showing it to you. Has the Alcon representative came to you and told you that you have a double foot petal to inject perfluorocarbon and silicone oil, and what is the technique of doing that? Because we depend on the information by the owner and the industry. We don't exchange. That's why Retinawesome is such an awesome thing to be done, because it's always full of tricks, tips, and tricks. I was very carefully listening to the range of systems that can be applied, and before that, and I was really teaching myself from these tips that you gave. I mean, I know that the yellow filter is to enhance the blue. I know that the green the filter is to enhance the green, or the saturation. What is the saturation? It's everything. We don't need a nurse next to us anymore. We need a mechanic next to us. We need an engineer, an electronic. We can fix our screen. You can fix the saturation. You can fix the colors and tell him, I need to have a better visual result. And at the end, we might happen to have to check each ophthalmologist to a specialist to check his peak of colors in his eye, because everybody's eyes have a different color peak. So thank you for Retina, and thank you for the tips. I'm really educated, and we have to persuade people to look at that, because nobody's going to come and tell you this simple dual feather technique of the Constellation.
Can I add something on the dual technique, please?
Yes.
So as Professor Athanasius said about the dual technique, you actually press on the first stage is injection, and then you press more with the for the vacuum to aspirate the PFCL. I actually set the injection on 70 or 80 with 5,000 centistokes, and vacuum on 400, about 400. And if you want to decrease
just hold on 1 minute. Vacuum, to my mind, should always be 650. Never.
And you press
5,700. You have to put the whole vacuum 650, because you need that exchange to a 25 gauge when you have
yeah, I always use the 25 gauge. But one thing I want to add on the Constellation options is that there's an option that you can toggle between the vacuum and the injection in the same VFC injection option. That if you find that there is an increase in the IOP, you just toggle it for the vacuum only, and you aspirate, just aspirate. And if you want to inject some more, you just toggle between the options. That's also an option that I learned of about recently in the constellation, and nobody told us, as Dr. Taneja said.
Well, and don't forget, everybody, when they inject silicone oil or when they try to exchange something, what about the infusion line? Because you got an infusion line. The infusion line should always be on 25. It should be switched on. That's nobody tells you that if you have your infusion switched off in order to inject something, it's so small, the tubing you've got, there is no time to fill the eye with silicone oil if you don't have the infusion constantly on. So the infusion should be on until the last drop of silicone gets into the eye. Then you switch off the infusion. Then you look at the gas bubble that you have because you're injecting or what at the end. And then you finish the silicone oil. Because another question with silicone oil is, when do you stop injecting? Where do you have a filled up eye completely? Because you need a complete fill if you want to fill the periphery at the back. That's another question.
I actually wait. Wait till the silicone touches the crystalline lens, and I actually remove the infusion. I usually use the chandelier. Then there is no infusion. This sclerotomy is closed, and I use the dual filter to end the surgery, and until the PFC is gone. And it's actually very obvious because the bubble is not immiscible with the silicone, as you know.
When you switch off your infusion, you have a filled up eye.
Remove it.
Infusion on. When you fill it up, you have a very tough eye. But when you switch off the infusion and you wait for a few minutes, you see the eye goes back to normalized because you don't have the infusion on at the time. And then you can remove a few droplets or at the end. And then the way to leave the eye comfortable and the eye not to be painful, the eye not to have raised pressure and everything, it's on those details that you told us. You're controlling yourself, but you learn it by experience. There is no booklet to tell you how to do it. It's a crazy thing. Nobody tells you that this is capable. I was lucky enough to be invited when they have the Accuro system. Being old, you have a benefit. You have experience. You know what? You don't use it afterwards. But having the Accuro system, Alcon invited 5-10 surgeons in Hong Kong to learn how to improve the Accuro system. And we've been asked to do this and to do this and to do that. And now the Alcon doesn't transfer this kind of knowledge that we share between us in order to evolve. Because Hucolac used to make this constellation, there's a history behind it. Who made it? Do you know, we used to inject through 25 gauge infusion by using 55 millimeters of pressure because we didn't have any system to inject it before. So it's an evolution that is going on. And you pick up the evolution, and you're rather young, and you know all the tricks and tips, but you don't tell them to other people. So we need to have a session in TVRS. We have a session, and we'll have a session in Uretina saying how to inject and remove silicone oil. And that's it. It's a whole class by itself. And thank you for sharing, and thank you for telling me a few tips yourself to me. Thank you.
Thanks a lot. Great knowledge and great experience. We really need to share those info, of course. And Vaibhav, do you have any comment for this technique?
No, I think Dr. Ahmed and Dr. Athanasius have told us some very interesting tips, the toggle and as well as the infusion line. I think these are very, very important things which are in between the lines. We don't really always get to know about them unless you experience them yourself and then you modify your technique. But if you're not using the constellation, then you can use a passive system of PFCL aspiration like we normally do with a flute needle. But it's always better to have the dual system if you have it available.
All right, thanks. And before I call Marcelo to share his case, Marcelo Murilo Sasamoto, my friend and neighbor here from Bolivia. And I just want to say hello to Maximiliano Bitar. Maximiliano is from Cordoba. We were together in Cordoba, in Ophthalmo Cordoba. Thank you, Maximiliano, for being with us and sharing your experience as well. So, Marcelo, how do you do?
Awesome. I was with some problems in the clinic, right? But now I'm really, really free. I need to give a presentation about scleral fixation lens and a new technique that I'm creating. So I'm gonna share my screen. So the thing is that you see my screen?
Yeah, it's not full screen, but I see.
So actually, we create this technique for those patients of ROP and late ROP, and which is the best option to do this type of surgery, and which is the best technique for those children who need intraocular lens. So we started with transscleral fixation, and then we changed with Yamane technique, and now we are starting with these five cases of this modified Yamane technique. We were joking with Hudson in Ophthalmo Cordoba, the name of the technique, and we call it Yamane Sasamoto. Just kidding. So what we did at the beginning was, this was a patient with a blunt trauma, and we did actually was a blunt trauma, and the intraocular lens was a 3-piece IOL in the posterior pole. So we use the 3-piece IOL to fixate the lens. So this is a variant technique of the original Yamane, where we use the trocars to pass the optics of the lens. We make a large flange, as you're gonna see, a large flange, and cover it with a scleral patch. And the objective of this is to, as long as the ocular globe is going to grow, we need to see how the tissue is going to react to these optics and the material also. So what we did was showing the optic to the other side through the trocar, a big flange, put some glue, tissue glue, and then put the sclera and close it in the conjunctiva. Simple as that. We have 5 cases, and we are controlling them. And we know that there's no perfect technique. We are looking and searching for the best techniques in these patients. We know also that in the future we need a more consistent technique to offer kids and these patients. This is a post-op, 1 week, I believe. There's no tilt in the lens, so the patient is going well. So that's the technique. Thank you.
Yeah, and the lens, how do you call this? You call it Sasamoto Yamane? That's nice. the 2 Japanese.
We were joking about that.
You should include me. I will try doing some cases. You should do it, Nakamura Sasamoto, as we found a partner from the Japan, Mura, Dr. Mura from from Argentina in the meeting. Congratulations. And what about you guys? Do you like doing this technique? How don't we ask Maximiliano? Maximiliano, can you hear us? Could you comment on Marcelo's case? You were with us in the Oftalmo Córdoba meeting. That was awesome. If not you, anybody else would like to comment on the Marcelo's technique? Thanasius, how often you do scleral fixation? So, Marcelo, how do you compare those cases? How different it is from Yamani technique, and if you compare to Agrawal technique, about the time the haptics last without having the lens fall back. People usually comment on that. How do you think the intrascleral tunnels, how could you avoid this situation?
With some patients, ROP patients, they have some difficulties with the optics, no, the extrusion also. Even though I use these scleral pockets and use the technique as I was reading, so I believe that I had some patients that in 2-3 years there was this extrusion of one of the optics without moving the lens. But in the future, I know that there's going to be some troubles with those patients. So what I keep on my mind was what can you offer to stop the tilting and also to cover the optics that's going to give you that tilt movement in the future. And a good example was the helmet valve that you use sometimes with a scleral patch technique. If you see through the years, this patch don't move, stay along the tube, and that was a good example of how a scleral patch can work with the optics and also the flange that must be bigger than the usual, so you can combine both and work with that. It was just I have small cases, and obviously we need through the years see how it's going, but it was an idea that came to me, I believe, 6 months ago.
Right, thanks. And Natarajan, good evening for you. Do you have a case for presentation? Did you get to the hotel? If not, let's wait for Natarajan. I'm not sure whether he has a case, and I'm gonna show you a brief case of mine. Which is here. Yeah, that's the case. And so thanks for everybody for the session today. It was great to learn FA and vitrectomy and get more interested and share it with your friends and around the world. So I have no conflicts to disclose. These are our attachments here in Brazil, in Canada, France, and have the pleasure, together with friends like Natarajan, Tanasios, Vibhav, and Sasamoto, and others here, to be part of Retinawesome since the pandemics. This was our meeting back a month ago in Cordoba, on Ophthalmo Cordoba. This is available online as well. And so this is just a short video that I wanted to share you. So this, I presented this in Ophthalmo Cordoba, but actually at ESASO we had this meeting as well. And this is how you could approach doing a vitrectomy with a small pupil and some different cases where you don't have good visualization. Like here, you've got this almost full thickness defect. I'm gonna show you again here. You see it's a pseudomacular hole with epiretinal membrane, and how tiny is the pupil and how cool is the imaging. And so would you operate those cases with such a small pupil, or you're better off doing the cataract surgery before? So, but you see how you've got some cataract here, irregular pupil due to uveitis, but still there is a good dilation, enough dilation so that you could see what you are doing. And after vitrectomy and brilliant blue, now you separate the epiretinal tissue from the internal limiting membrane. You see that the approach is very gentle. You still see through this small pupil. You gotta be very careful not to touch the lens, so that you do the surgery very gently. And now I'm using the macular lens and another air fluid exchange. In this case, I put brilliant blue, so in that way it was easy to see the ILM. So this is another fast case that I do as an inverted vitrectomy. So why double stain, and when do you double stain or just stain once? So in such a case, you have this taut epiretinal membrane and tissue. Everything is kind of pulled up. The patient is phakic, very clear lens. So you see like a plaque, this macular pucker very attached to the posterior pole. So I see vitreous here. That's why I don't like doing the triamcinolone, because I like seeing the vitreous. I do core vitrectomy, and after doing core vitrectomy, I love to use the macular lens so that you see the vitreous better. So it's good that you remove, you see here white without pressure, you see the vitreous, you see the attachments. Everything is so clear now. You've got no more attachments from the hyaloid, and so that's time that you perform a complete air fluid exchange. And by doing the air fluid exchange, a complete one, you get a better stain of the brilliant blue. But of course, if you've got this pucker, you are not going to be able to see the internal limiting membrane, because it somehow covers the ILM. And my first approach here is to remove the epiretinal tissue, the pucker itself. You delaminate it, and it came off like a veil. It's a very good technique, and now it's possible to separate the epiretinal tissue, the epiretinal membrane pucker. You see the macula is free now for another air fluid exchange and the staining. Sometimes I do staining right away because now you don't have the membrane over the retina, and now without doing the exchange, I just injected brilliant blue again. I'm using this large macular lens. And now you see much more because actually the macular pucker was covering everything. You were not able to see the ILM. So it's possible to remove now the ILM because everything was so contracted. As you saw in the B scans from the OCTs, these things were so attached. You find here an edge. You gotta be very gentle. And now it's time for removing the ILM. So interesting, when you remove the ILM, you see that things like relax. You don't have those contractions anymore. In this case, the macular pucker left these vessels changes like that, contractions. And you gotta relieve as much as you can. And you see that the central area, including the fovea area is now free. But you see everything so attached. When you get something, everything starts to come. So you gotta be very slow at this time and have a good lens, and have a good approach so that you can see the macula well. Now, endolaser to avoid any rupture that you might have created during the maneuver of vitrectomy, but sometimes it's only useful to do the laser at the very periphery. And you see the end result, a clear lens. Now post-operative period number 8, you don't see the pucker anymore. The lens is very clear, so you did not touch the lens during vitrectomy. And this is amazing to see how you can do the surgery without removing the lens. And you see you have lots of cysts, even though we removed the ILM due to the long-standing period that this was there. So the patient could benefit from some intraocular injections as well, so you carry on the case. So I really appreciate you watching us here. Interesting cases, and I have to tell you guys, I learned it a lot from the FA meeting and from some of the our cases, and I love the advice from Athanasius as well. And if Natarajan is around, I would like him to comment. If not, Marcelo, what do you think about these approaches, double stain?
I think a wonderful approach, Hudson. Great. I was quite spectator today, but I think wonderful. And I think today's your case is really interesting and a good lesson for a surgeon.
Yeah, thanks. And are you in Nepal, or you just came back?
No, I arrived in Mumbai now. I reached home now.
Okay. Natarajan, you like double staining or just stain once? And do you like double air fluid exchange or just do one air fluid exchange? Do you have to do injection because you remove the epiretinal tissue? Do you do another exchange or just a pull? Inject the brilliant blue?
No, in case I not able to do in full, then I do double like you. Not in every case.
All right, thanks. And Marcelo, what do you think?
I believe it's a really good option. You show us in Cordova your technique also in your case. So it's a very useful technique, I believe. We both have some difficulties at the beginning, but it works with double stain.
Thanks a lot. And thank you very much for these beautiful sessions. And I'm I think I have the same thought as Athanasios. Athanasios, in these situations here, in those meetings, that's the time that we have to discuss different things that we don't see really written in the books. So this comes from experience. And I would leave up to you, Athanasios, to close this session, unless somebody else has another case to share, and you could close the session, Athanasios, please.
I think that I learned a lot this time. You're combining innovations like the fluorescent with Alan Franklin, and all the friends that are doing it, and also all the difficulties that each one of us having to share with other people. I think Retinawesome should continue in this new way of we don't have to do it now, but we need to do it. So thank you very much, everyone, and you are welcome to the next session that I will always follow you. I'm a follower now, like everybody is doing, but I'm a follower of Retinawesomes. Thank you very much for inviting me. I learned a lot.
Thanks a lot, and these videos are going to be available within probably 2 or 3 days, edited, and we are going to be very happy to share it to the ophthalmological community, especially those fancy techniques that ophthalmology and especially vitreoretinal surgery is facing today. Thanks a lot. Thanks, Natarajan. Thanks, VibeHav and Sasamoto, everybody, for being part of this, for me, a great course.
Thank you, Hudson. Thank you, guys.
Nice to see everybody.
Thanks. See you. Say hello to Arun.
Yes.
Bye.
Have a great day.